Welcome back to the Compact Echo course. In the next few videos we will talk about the apical views, and we will start off with the apical 4-chamber view. Well, the apical views, they are located, as it's already in the name, at the apex of the heart. Especially you want to focus on the left ventricular apex. Keep in mind, compared to the parasternal views, you're way more lateral and of course more caudal. It will be in the range of the fifth intercostal space where you find the apical views, the apical 4-chamber view, in this video especially. But keep in mind it's highly variable. The marker should point in the cardiac preset to the left lateral of the patient. The patient shouldn't be, compared to the parasternal views, not strictly in his left lateral position, because you need a little bit of more space for the transducer on the lateral side. Alternatively, you just can remove a part that you can scan better, but we in our Echo Lab, we simply do not place the patient strictly left lateral. The view overall is, as I said, highly variable. It is highly dependent on the body type, and of course you should tilt the transducer towards the left ventricular apex to actually find the 4-chamber view. There are some problems, of course, when the patient is severely obese or slim patients as well. It could be hard to find an optimal or a good view. You can use contrast in those patients to optimize your image quality. In COPD patients, it can be sometimes hard to get parasternal or also apical views. And in case of breast implants, sometimes they are just in your field of view, so it's harder to scan those patients. The 4-chamber view, you can see that the marker is left lateral. Then with a rotational movement, you get to the 2-chamber view and the 3-chamber view, the also so-called apical long axis view. You rotate counterclockwise for those views, 60 to 90 degrees from the 4-chamber view to get to the 2-chamber view, and 30 more degrees approximately to get to the apical long axis view. If you tilt the transducer to be more steep, I would say you can get the aortic valve and find the 5-chamber view. And if you tilt the other direction, so optimizing the view away from the aortic valve, it's called the coronary sinus view. In case of the 4-chamber view, well, it gives you the overview of all 4 cardiac chambers. The left ventricle, seen over here, has to be bullet-shaped. Of course, the left ventricular wall should be thicker than the right ventricular wall. That's due to, of course, the pressure difference in those chambers, and of course you have to find valves and valvular structures. So here's the mitral valve, the anterior, the posterior leaflet of the mitral valve, and here's the tricuspid valve, where you can differentiate the septal leaflet and here the anterior posterior leaflet. The left ventricle should be larger than the right ventricle. Overall it should be 2 to 1, but also keep in mind that there are simply differences in anatomy depending on the body shape and also what you will find when you're scanning the heart. And a very important point I want to state is that you should avoid foreshortening. We will discuss foreshortening in some later slides, but keep that word in mind. When the ventricle is not scanned really directly at the apex, you have foreshortening and oversee some relevant pathologies. The left ventricle is a truncated ellipsoid. You see this bullet shape over here. Here you see the cavity of the left ventricle. The contractility of this left ventricle is fairly good. The ejection fraction is in the range of 55 to 60%, I would say. And you see that all walls are contracting quite nicely. This is a focused view of the left ventricle, so the atria, they are completely cut off. This gives you even the advantage that you see the ventricle in an optimal position. The geometry already can give you a lot of hints towards which pathology might be present. Here you have several examples of pathologies, and we will discuss all of them one after the other. So on the left hand side, you do see that's the normal left ventricle we have seen. We have the focused left ventricular view, the good contractility of the left ventricle. And on the right hand side, we do see a pathology. We do see a pathological finding. This is also a more focused view of the ventricle, so the atria are cut off a little bit. You do see the right ventricle over here and the contractility of the right ventricular free wall. That's actually looking fairly good. The valves look also fairly okay, but there's a problem with the left ventricle. You do see that ejection fraction must be reduced because there are areas which are not contracting properly. Here you see there's a hinge point. So from that point on, we have a wall motion abnormality. That was an anterior STEMI, so an ST elevation myocardial infarction. And you see quite nicely that here the wall motion abnormality, the LAD territory, is differentiated compared to the here hypercontractile basal and mid segments due to the lack of the apex in contraction. Moving forward, we have another example we do see in this case, again the normal heart, and here something looks entirely different. The walls of the left ventricle, they are thickened. This is a patient with severe hypertensive heart disease with remodeling. A remodeled left ventricle means that there's fibrosis present. You see that in this case, the walls are thicker, the cavity of the left ventricle compared to the normal variant over here is smaller. Ejection fraction is still in the normal or just mildly reduced range. I would have said the ejection fraction is around 50%, but even though ejection fraction is normal, this heart definitely is not normal. The left ventricle shows damage from hypertensive, long-standing, severe hypertension. Moving on to the next patient. This is a patient with dilated cardiomyopathy. You can see the full case in another video. You can get the link in the box over here. And you do see also it's distinctly different. The ventricle overall is larger compared to the one on the left-hand side. The walls are really thin. You could think that there's also wall motion abnormality here, but overall it's a severely reduced left ventricular function we can see here. Also compare the left heart, so here, with this heart on the right side. You do see that also the right ventricle is dilated and the function is definitely reduced. So this is a dilated cardiomyopathy after myocarditis. Another example I want to show you is a heart transplanted patient. You do see again that ejection fraction here compared to the example before is way better. It is in the range of 60%. But what we can also appreciate is that the myocardium is thickened. A heart transplanted patient with a thickened myocardium always has to raise the doubt that there could be a transplant rejection present, which was actually happening in this case. You do see the thickened heart, but the good contractility. If we do look towards strain imaging already was markedly reduced. Compare it again with the left-hand side, where you see the normal heart, but also a transplanted heart by means of the left ventricle should look like. So the walls should be not thickened. In this case, we have another patient with coronary artery disease. This is a patient after myocardial infarction, and you do see that here the parts of the septum, especially the basal and the mid portions of the left ventricle, they are very thin and hyperechoic. This is a scar. A coronary artery disease led to myocardial infarction, led to scarring, so remodeling of the ventricle. You do see that here is again a hinge point, so where the myocardium starts contracting better. And when you take a look over here, then in this area again, we have no contractility. So here again is a scar. Here we do see the basal parts of the anterolateral wall, they are contracting, but here we also have scarred tissue. So always keep in mind that coronary artery disease after myocardial infarction can lead to scarring, which will present in a very bright, echogenic, thin myocardium. So it should be thinner than 6 millimeters in this area if it's really a transmural scar, which was actually the case in this patient. Moving on to something I truly like to perform, it's contrast. Contrast imaging gives a lot of detailed information about the heart. And in this case, the patient was a very young patient with formerly known cardiomyopathy known as non-compaction cardiomyopathy. Nowadays we call it hypertrabeculation of the left ventricle with heart failure. Her strain was reduced. Initially, ejection fraction was in the range of 20%, but with heart failure therapy, it improved significantly, as you can see here. In this case, it's around 45%. 45%, and you do see those hypertrabeculations all over the place in the apical and also mid portions to a certain degree of this ventricle. Overall, the ventricle seems comparatively thin compared to this normal example, and you do see that the walls are now dark. So the cavity is filled with the bubbles over here, and that's why you can see those trabeculations, that there are no thrombi present, that it is really a ejection fraction in this range of 45%. With contrast, it's simply easier and it gives a lot of additional information and it makes the detection, and that's also important with hypertrabeculation of thrombi, easier. Moving on to the next case, this is a case of a so-called apical hypertrophic cardiomyopathy. You do see here the whole cavity is not yet filled with the contrast, but you can nicely see the contrast in the apex. And what you can appreciate is that there is no aneurysm. So in patients with hypertrophic cardiomyopathy, with patients where you do not see the walls properly, where you can estimate ejection fraction when the hypertrabeculation is present, I would always recommend to use contrast imaging. Because with contrast you can way better delineate it there. In this case there is no aneurysm. If there would be an aneurysm of a certain size, about 15 millimeters, anticoagulation actually is mandatory in those patients. So you can see that here the heart fills, and even up to the apex where we see the most hypertrophied segments in this apical hypertrophic cardiomyopathy, also called Yamaguchi syndrome, you do not see thrombi, you do not see an aneurysm, and again, contrast gives a lot of additional information. Overall, ejection fraction is normal in this patient. Of course, due to the hypertrophy, also parts of the ventricle are simply smaller, so even the ejection fraction can be overestimated compared to the true left ventricular function which is present. So to give you the overview of the four-chamber view, the four-chamber view is important. You have to simply try, see, and learn. Use contrast if you do not see the endocardial borders, if you want to find thrombus, or in patients with coronary artery disease, with hypertrabeculations, with masses, tumors. Use contrast if you are not sure. Use contrast to detect aneurysms, pseudoaneurysms, and the shape and the form of the ventricle, of the left ventricle, already gives away a lot of information of what the underlying pathology you're dealing with looks like. And very important for the future views, keep the left ventricle in the center. So if you want to go to two-chamber view and an apical long axis view, keep the left ventricle in the center and not, as it is sometimes written, the interventricular septum, because if you rotate around the septum, you will always lose the chamber. But if you have the chamber in the center of the image and you rotate towards the two-chamber view, 90 degrees or 60 to 90 degrees, counterclockwise, you will always get the left ventricle and the left atrium in your field of view. I want to discuss some atypical views. So not always you can see everything with the four-chamber view optimally. Then it is time to move the transducer. You can move medially so that you see the lateral parts of the left ventricle better, so the anterolateral wall. You have here the traditional four-chamber view. And if you move more laterally and tilt inwards, so here you can tilt from the medial position a bit outwards, so laterally, and here you move laterally and tilt inwards, you get a nice glimpse of the right ventricular free wall. So you can move around the transducer, you can relocate the transducer and tilt to optimize your views and to get specific views for specific structures you want to see. So in case of the medial view, you have to really differentiate and delineate the anterolateral wall. It is good to find defects of the septum and also of the atria, because there's a little bit of tilting involved, so you see jets probably better. And of course for wall motion abnormalities. And in case of the right ventricle, move laterally and you see here the free wall of the right ventricle. It even makes the measurements way easier. So here's the right ventricular and the left ventricular apex, so you should focus on those regions to truly delineate and depict the RV free wall, to measure the strain, the S prime, and of course the TAPSI. Here are the examples where you see the various transducer positions. Here you have the more medial view where you see the anterolateral wall, the traditional 4-chamber view. And here the focused view of the right ventricle where you see the free wall of the RV. The beam orientation, of course, is key. So you can also adapt the beam orientation. As you can see here the apex of the right ventricle is not seen. When the beam orientation is adapted and optimized, you can even see the apical regions of the right ventricle. So by means of beam orientation, you can use that and still use strain imaging. The beam orientation or also other features by means of changing the imaging or the angulation of the imaging, it doesn't really affect your measurement. So in this case, you still can use the TDI measurements, the S prime, the TAPSI in this area, and also the right ventricular free wall strain. So if you cannot see all the structures, keep in mind that you also can optimize beam orientation. Some structures I also want to mention, because I do think they are important to visualize, are the pulmonary veins. So overall, they are not always easy to find, but with, of course, better and better machines, it becomes easier to visualize them, it becomes easier to measure. Keep in mind that there are 4 in a normal anatomical setting. The left pulmonic veins, you can see here the left lower and here the left upper. And here, of course, measurements make less sense compared to the right upper pulmonic vein, because here you see the beam orientation is simply optimal. The right lower in TTE, from my experience, it's not possible to find. Also in TE, it's sometimes very difficult to visualize all 4 pulmonary veins, but at least keep in mind that the right upper can be visualized and used for measurements optimally. So if you do that, you see here a structure, a vascular structure. Here's another structure, but that might be the left atrial appendage. But in this case, with color Doppler, we do see that there is flow coming into the left atrium. Here you see the blood flow. Of course, this is not optimal for measurements, Doppler measurements, of course. So we have to find here another structure that must be the right upper pulmonary vein. And now optimizing towards the right upper pulmonary vein and placing the pulsed wave Doppler, we get a signal. We have an S wave and a D wave. So a systolic and a diastolic wave. Sometimes we have an additional notch here in the S wave. And so the S1 and the S2. But in this case, we have a nicely depicted S wave and a D wave. Normally, the S wave is larger than the D wave. In this very young, healthy, and fit individual, the D wave is a little bit higher than the S wave. This could be a finding in young and healthy athletes, but normally when you see it in an elderly patient, it also can show elevated feeling pressures. And that's what the pulmonary veins are actually for. They show the overall entering of blood flow into the left atrium and therefore are involved in elevation of feeling pressures. And here you have the old nomenclature of feeling pressures of diastolic dysfunction, but overall what you can nicely see is that there are several measurements we have. We of course have our pressure curve, which rises initially when we have a restrictive feeling pattern, and the mitral inflow, the E to A ratio, here the very high E and the small A wave in this restrictive feeling pattern, and the IVRT, the isovolumic relaxation time. You can also go watch the entire video of diastolic dysfunction, where also the IVRT, the isovolumic relaxation time, is featured. For a ground rule, the IVRT has a certain length and it becomes really short. It depicts also elevation, significant elevation of feeling pressures. And the pulmonary venous flow is the same. We have the S wave, the D wave, and we have another segment which is called AR. That's a reversal of flow. And the more the flow reversal is, the higher the feeling pressures are, and you see that the S wave compared to the D wave becomes significantly smaller, which also depicts elevation of feeling pressures. The AR is also a good sign, so if you have a young healthy athlete, you do not want to see a prominent AR wave, but really just a small, as you can see here, reversal flow, but the S and the D wave, as I said, in young, healthy, fit individuals can look a little bit different by means that the S wave is a little bit smaller than the D wave. Furthermore, we have the mitral annular velocities, the E' measurements, and the corresponding towards the A wave, the A', where we look at the E' mostly, and here we see the E' in these various settings where the filling pressures are elevated. The lower the E' is, also compared to the E to E' ratio of the restrictive filling pattern, it shows elevation of filling pressures. Now you see here again with the naming of the individual curves, you have here the S wave, the D wave, and this small insignificant area we have the AR in this young healthy person. Now, as promised, we have to talk about foreshortening. By means of foreshortening, the transducer is simply too much cranial. That is why we do not cut the LV apex but the left ventricular walls. And by doing so, we can never see the true apical areas. And here's an example which is nicely seen that the papillary muscle reaches almost the apex, which cannot be. So if you see the papillary muscles in the last third of the ventricle or reaching the apex of the left ventricle, there must be a problem. So mostly it's foreshortening, so you have to move one intercostal space down. The second thing you can depict here is that the left ventricular apex always moves inwards the left ventricular cavity. That is also a feature which is either pathological or simply you do foreshorten. Always when you see those features, or overall I would say, always try when you have a good view of the heart to move one intercostal space down, just to be sure that you are truly seeing the apical regions. Also try breathing maneuvers. So if you see an image like this and then you go more apical and then you do not see the left ventricle optimally, let the patient inhale, let the patient exhale to see if the image quality might change. Very often it actually does, and from my personal experience with inhaling, you often see the left ventricle even better. So keep in mind the optimal orientation. Avoiding foreshortening is essential to perform good echocardiographic exams. Yes, foreshortening is bad, of course. Here in this very severe example of foreshortening, we have really small left ventricular volumes. We overestimate ejection fraction. We do not see the apical region, so we do not see wall motion abnormalities. We do not see thrombi, and we do not see, for example, an apical hypertrophy or also hypertrabeculation. So keep in mind, foreshortening is truly bad. How to avoid it? Move one intercostal space down. As said earlier, just try one intercostal space downwards and overall more lateral, more downwards for the apical views. And if you have an optimal two-chamber view, you can see that foreshortening can be avoided in this case. So the true left ventricular apex normally, not in this case we have again the apical hypertrophic cardiomyopathy, the apical regions, really the apex, it is very, very thin. You can see that in MR quite nicely when you truly depict the left ventricular apex. So keep in mind to optimize your image, the field of view, and in an optimized two-chamber view, you can avoid foreshortening. Why should we use then the apical four-chamber view? And the other question around is, why should we not? The apical four-chamber view is simply amazing. You can see the global left ventricular function, you can see right ventricular function, you see the chamber dimension, you see the chamber dimensions of the left ventricle, the right ventricle, the left atrium, the right atrium. You see the interventricular septum, you see the interatrial septum, you see almost all the valves you want to find. You see tumors, you see free fluids, so pericardial effusion, thrombi. So with the four-chamber view, that is the view you want to go in cardiology from my personal standpoint. And here's an example of a severe tricuspid regurgitation after a triclip. So you see that every valve, every chamber, every structure, even clips, can be visualized in echocardiography. Here's another example of a four-chamber view, and there's a problem with the valve. You see the left ventricle seems borderline in size, almost a little bit dilated already, and you do see that the valve has a problem. There is severe mitral regurgitation. It might not look like this initially, but you see the hyperdynamic LV function, you see the eccentric jet. That is a patient where a flail leaflet was present. So severe MR with a flail leaflet using color Doppler and the apical four-chamber view. There are some rare structures you also can visualize, and in this case, we found a pericardial cyst. So here's the right ventricle, the left ventricle, the right atrium, and the left atrium. Here you can depict the left atrial appendage, and this below the right atrium, there's a structure. There's no blood flow in it. You can see that again with contrast imaging, left atrium, right ventricle, and left ventricle, and this black structure stays, as it is seen here, black. So there's no blood flow present. That turned out to be, and it was proven by an MRI, a pericardial cyst. You can differentiate several diseases, or at least get an idea which disease might be present. In this case, we have amyloid heart disease. Note the dilated left, the dilated right atrium. There's also atrial fibrillation present. See the valves, how they are closing prematurely, both the mitral and the tricuspid valve, the anterior and the posterior mitral valve leaflet. Here the anterior-posterior leaflet of the tricuspid valve, and here the septal leaflet, the severely concentric, thickened left ventricle. You do see here the chordae tendineae, the papillary muscles, and a patient with already, even with this severely thickened LV, a reduced left ventricular function in amyloid heart disease. Or to be more specific, a left ventricular ejection fraction, which is reduced, of course, left ventricular function is, in this case, probably severely reduced by means of strain imaging. This patient had a strain, a global longitudinal strain of around -10%. In this case, we have another example of a thickened heart. This is so-called hypertrophic cardiomyopathy. Note that right ventricular function, as there is no involvement, the right ventricle is not really hypertrophied, is normal. The atria are smaller compared to the patient with the amyloid heart disease, and it's simply a very different feature how the ventricle looks. There is no LVOT obstruction. We have here again the mitral valve leaflet. We do have a part, I would say, caudal SAM. So the SAM is the systolic anterior motion of the anterior mitral valve leaflet. In this case, we do see that this SAM occurs only for the chordae tendineae because there's a little bit of acceleration in blood flow, of course, at the outflow tract. We do see this especially at the septum hypertrophied ventricle with a high normal ejection fraction in the range of 60 to 65%. We do see also a hypermobile interatrial septum, and the thickening in especially the septal regions is severe, but also the anterolateral wall is thickened. The papillary muscles are also hypertrophied. Two more examples. This is a patient with heart failure with reduced ejection fraction, so severely reduced ejection fraction, with another pathology, a left bundle branch block. You see this rocking motion of the apex, you see this septal flash, so it's an ineffective contraction of the ventricle. You see the broad ECG, so a left bundle branch block seen in this example. And here we have a patient with a left atrial tumor, which turned out to be a myxoma. So with the 4-chamber view, you really truly can differentiate many pathologies. Furthermore, you can use Doppler, and one specific Doppler measurement I want to show is the Doppler measurement of the mitral valve, so the measurements of diastolic dysfunction. And here you can nicely delineate the E to A wave, and here we have the systolic part, which is not depicted because the pulse wave Doppler is not across the LVOT, but this E to A ratio is important for diastolic dysfunction. It's important for understanding the timing. Is the sinus rhythm present? It can vary in case of tamponade or pericardial constriction, so you will have a different inflow pattern over the time, so with a larger and a smaller E wave in tamponade and constriction. Moving on to the right ventricle, we want to talk about the TAPSE, the tricuspid annular plane systolic excursion. You measure the TAPSE at the area where the left ventricular free wall is at the tricuspid annular plane. So here you want to perform the measurement. You can do the same with the mitral valve, the mitral annular plane systolic excursion, and with both you can see how left or right ventricular function by means of an M-mode measurement truly looks like. So the value should be above 70 millimeters, and that is how it's done. Here you see the M-mode measurement through the lateral wall, the tricuspid annulus, and here you measure this curve over here. So you start from here and measure to the top of the one bright line you can follow optimally. So here I would follow this bright line all the way through, and this measurement, of course, in this case is above 17 millimeters. With a focused view, it works the same. So you should place the M mode just at the lateral tricuspid valve annulus. With the mitral valve, you do the same. Here the cutoff is a little bit less compared to the tricuspid valve. For the TAPSI it was 17 millimeters. For the MAPSI it's around 10 to 11 millimeters. So here you see the M mode and the measurement and the line you would follow. So here you would place the M mode as seen in this example. Keep in mind, M mode measurements are sometimes very difficult to interpret by means of, just imagine you have a wall motion abnormality in the specific area over here. You have a large apical aneurysm. Of course, with those measurements, you have the limitation that you only see a very small part and a very limited measurement of what actual left ventricular function or left ventricular contraction or right ventricular function and contraction looks like. For example, in pulmonary embolism, very often the apical segment and also the basal segment, they are contracting better compared to the mid portions of the ventricle. So still, if you have a normal TAPSI or MAPSI, it doesn't rule out left ventricular or right ventricular dysfunction. Another measurement you can perform at the same place where you would place the M mode. Here you use the TDI measurement, so the tissue Doppler imaging. With TDI you have also these color maps as in color Doppler, and you do see measurements and velocities. The velocities are way lower compared to color Doppler because it shows the values of the myocardium which is moving, so displacement, and you use the pulse width Doppler to see this curve. So we have here the S primes, E and A prime of the right ventricle, but we want to measure this S prime, and if it's above 9.5 centimeters per second, it's normal. So another measurement you can use additionally to quantify longitudinal right ventricular function. Here are examples of pathological measurements. You see a patient with a dilated, severely dilated right ventricle, dilated left ventricle, dilated atria, severely reduced left ventricular function, also severely reduced right ventricular function. You do see here the measurement of the TAPSI. It looks varying because the patient also has atrial fibrillation, but it's definitely reduced by means of the S prime. It's also reduced in the same patient when you perform this measurement. The tricuspid regurgitation is something you always have to try to find. Very often it's simply difficult and it won't work all the time. So don't be discouraged, but always try to find this small, even flare over here and then place a continuous wave Doppler to quantify the tricuspid regurgitation to calculate the systolic pulmonary arterial pressure. The degree of TR doesn't resemble pulmonary pressures. That is also an important point. In this case, we have the tricuspid regurgitation. We see it's over here, it's physiologic, so it's mild. And with the continuous wave Doppler, we get this nice signal where we can actually measure the TR velocity. This is an optimized view. On purpose, some foreshortening present. You see here, the right ventricle and the left ventricle, they look rather round. It is one intercostal space up, so an foreshortened four-chamber view. In case of TR, it is sometimes easier to foreshorten and move one intercostal space up to optimally visualize tricuspid regurgitation. In this case, we also do see TR. We have seen it before this ventricle, the reduced right ventricular, reduced left ventricular function, the dilated atria, and here moderate to even severe tricuspid regurgitation, I would say. And with the modified Bernoulli equation, we can measure the systolic pulmonary arterial pressure. In this case, the TR Vmax was 3.1 meters per second. And so with the modified Bernoulli equation, you calculate 4 times 3.1 square. So the TR velocity square equals the SPAP. And in this case, it was 38.5 millimeters of mercury with a measurement, which was a mean measurement because of atrial fibrillation. When we then know how to acquire the 4-chamber view, it is time to continue with the apical views, with the 5-chamber view, the coronary sinus view, and also the atypical lateral view. The apical views are located at the apex of the heart, so the left ventricular apex in the 5th intercostal space approximately, but it varies. The marker also in this view, the 5-chamber view, coronary sinus view, and the atypical views points initially towards the left lateral. The patient is not strictly left lateral, and you tilt from the 4-chamber view towards the 5-chamber view, and in the other direction towards the coronary sinus view. Here you have the overview of the views and the tilting and the rotation again. So for the coronary sinus view, you tilt downwards, and for the 5-chamber view, you tilt upwards towards the aortic valve. The tilting upwards and downwards is the key to optimize your images and get optimal views. What can you see in a 5-chamber view? We do see it here on the graphic. We lose parts of the right atrium and the left atrium. Overall, the 5th chamber is not entirely correct. It's the aortic valve, so it's a valvular structure, which we call 5-chamber view. And the 5th chamber, here we have the LVOT, the left ventricle, and still parts of the right ventricle are seen. You see the most anterior part of the septum, and as mentioned, you lose some information of the atria and also of the right ventricle. How does it translate now in echocardiography? Here we have an echo image. Here we see the aortic valve as the 5th chamber. Some information of the right atrium and the left atrium and the right ventricle is lost, but still we can see in this patient with amyloid heart disease the severely thickened left ventricular walls, and here the LVOT and also the thickened aortic valve. In another patient, we can also use color Doppler to see if there is stenosis or regurgitation present. Here we do not see any kind of flow turbulence, so that is the normal flow towards the valve. We have a very, very small, insignificant jet right here, which resembles mild or minimal aortic regurgitation. Measuring the peak velocity is imminent when you are using measurements of the aortic valve. You have here the continuous wave Doppler, you have the focus of this line here in the aortic valve, and you see here that's the aortic valve signal. So here you would measure the peak signal. It should be in the range of 1 to 1.5 meters per second. Always keep in mind for this view you can move a little bit more lateral to have a more optimal angulation of the continuous wave Doppler signal. Using pulse wave Doppler, we also discussed it in the chapter of aortic stenosis. You can also see a great part of LVOT measuring and the videos about fluid status, about volume status. And here you place the pulse wave Doppler at the area of the LVOT. First, I would recommend that you place it in the aortic valve, move a bit backwards, and then you get this nice flow signal with a black curve in the center, which then is the LVOT curve, where you see it's also around 1 meter per second, which is normal. In case of aortic regurgitation, you have to visualize initially with color Doppler. You see here the small flare that is mild AR, a little bit more than the trivial we saw just in the case before. It's a central jet. It goes into the left ventricle. It borders here the sigmoidal septum, but it's not really hemodynamically relevant. We do see the left ventricle here, the sigmoidal septum, so the prominent septum, in a female patient in her 60s with hypertension. And you do see that the LVOT is a little bit narrowed due to the septum. And we do see this caudal SAM, so these structures, the chordae, are moving towards the interventricular septum, but not the anterior mitral valve leaflet. So it's a little bit of a flow turbulence due to a narrowing, but not hemodynamically relevant. Furthermore, note in this patient the overall small left ventricular cavity and the high normal ejection fraction. When this patient is hypovolemic, this gradient or possibly becomes hemodynamically relevant. Here we're taking a look at a patient. He had a repair as a child, a left to right shunt. Here we do see a rest of the shunt with a dilated right ventricle, which led to volume overload of the right ventricle and therefore failing of the left and the right ventricle. You see also the left ventricle is dilated, the ejection fraction is borderline to mildly reduced, and this was a still persistent shunt after a sinus valsalva rupture operation. The patient received another pericardial patch and no shunt was visible anymore. But that is something you can see quite nicely here when you visualize the aortic valve and the LVOT. Here I have examples of a patient who received a mitral clip, coronary artery disease, reduced left ventricular function, and severe mitral regurgitation. And due to the clip, there is a flow turbulence across the mitral valve inside the left ventricle. And here at the aortic valve, you have some flow turbulence, not a significant stenosis, and also a mild aortic regurgitation. So color Doppler very often can help to differentiate and to get an overview of what you might encounter when you use continuous wave or pulsed wave Doppler measurements. Here we have another example of why to use color Doppler in this 5-chamber view. Of course for AR, of course for aortic stenosis, LVOT obstruction, and also membranes are very important. And in this case, this was a point of care imaging device. You do see there's a valvular structure. It's a TAVR, and the leaflets, they look severely thickened. There was a case of endocarditis with, you can see here, the regurgitation. And by using color Doppler, you do see if there are also valvular lesions present, for example, AS or aortic regurgitation, as in this case. Why using pulsed wave Doppler? For pulsed wave Doppler, the usage is quite clear. We need it for the continuity equation to calculate the aortic valve area. So we need to calculate the overall square centimeters to quantify aortic stenosis. There's a whole video about the aortic stenosis, almost an hour long, so click the box and check it out for more information. To have a quick overview, you see a lot of measurements over here. Here you see the aortic valve area with the VTI. You see the aortic valve area is 0.52 square centimeters, which is a severe or even critical aortic stenosis. If we index it, it was a very slim and small patient. We get an aortic valve area indexed to body surface area of 0.348 square centimeters per square meter, also an equivalent of severe or even critical aortic stenosis. When we take a look at the VTI of the LVOT, that's normal, above 20 centimeters approximately is normal. When we look at the stroke volume index of 52.42 milliliters per square meter, that also shows that there is no low flow situation present, and the cardiac output and the cardiac index both are in the normal range. So you get a lot of information out of this measurement. The continuous wave Doppler has to be measured across the aortic valve too, and also the LVOT to quantify all those measurements. But overall, you get a lot out of this measurement by only visually assessing it and then measuring it. Also for shunt calculation, for example, just to mention the QPQS, it can be helpful. LVOT obstruction, midventricular obstruction can be localized with pulse wave Doppler as well. Why continuous wave Doppler? Here is again the patient with a severe aortic stenosis. We do see the maximum velocity is 6.2 meters per second, so definitely severe aortic stenosis. The mean pressure gradient, I just have to remind you that 40 millimeters of mercury mean pressure gradient resembles a severe aortic stenosis. This is above 100, even 106.19 millimeters of mercury when you measure this signal, and that's severely elevated. So this is truly a critical aortic stenosis. So we need that for the quantification of aortic stenosis as well. The continuous wave Doppler can also be used to quantify aortic regurgitation by means of a measurement called the pressure half-time. Here the continuous wave Doppler was used to quantify LVOT obstruction. This is a patient with hypertrophic obstructive cardiomyopathy. You can see the severely thickened hypertrophied left ventricle. You see the SAM phenomenon. And here with the continuous wave Doppler, there is a true LVOT obstruction of 5 meters present. LVOT obstruction and aortic stenosis are two different signals and of course two different disease entities. Aortic stenosis is a problem of the valve, calcification of the valve, and a narrowing of the actual outflow or the flow through the valve. The LVOT obstruction is something that is before the valve. It's a dynamic obstruction. You do see here the signal is more round shaped. The LVOT obstruction, it's more like a dagger-shaped form. When it is truly in the LVOT, it looks a bit less steep at the beginning. When it's mid-ventricular, the curve is even steeper and it looks sharper. Here we have the measurement of aortic regurgitation. We can grade it with the pressure half-time. You can measure it from here to here, and you can get several measurements. It's not always that easy. You really have to have the aortic regurgitation in the continuous wave Doppler spectrum. If it is above 500 milliseconds, it's most likely a mild regurgitation. In between 5 to 200, it's moderate. And if it's shorter than 200 milliseconds, it's a hint that this could be severe aortic regurgitation. So if the curve is really steep, keep in mind you need to have a really good curve, otherwise the measurement will be off. Now, to get the coronary sinus view, you have to tilt the transducer the other way. So for the 5-chamber view, you tilt more cranially, so more upwards, and here you tilt more caudally towards the coronary sinus. And there you see the most basal parts, the basal inferior septum, the coronary sinus, and the most basal parts of the ventricle. And the coronary sinus view, it looks like this. Here you have a patient with an Epstein anomaly. You see the left ventricle, the right atrium, and here the valve, which is inserts very high in the right ventricle. And here you have the coronary sinus, or the venous structure, which leads into the right atrium. And here you have an additional structure. This could be a valvular TBAC, so a very small valve of the coronary sinus, which is a remnant of early development of the heart, or it also could be rete chiari. But as there's only this small structure seen, it really could be the valvular TBAC. So the coronary sinus view, when you have a large coronary sinus like this, you have an extrasystole here, a large coronary sinus. This is the patient who had a ruptured sinus of Valsalva. There is another pathology or anatomical variant. You can see a persistent left superior vena cava. Here you can see the coronary sinus. So young patients with a severe dilatation of the coronary sinus most likely have a persisting superior left vena cava. It can also be a hint of an elevation of right atrial pressures. You can see the CRT lead sometimes quite nicely in the coronary sinus, or a pacemaker lead in patients used for heart failure. You can also, if there is treatment happening of heart failure, you can see other devices such as a reducer or a carillon system, and inferior infarctions you can also visualize in this area over here. By means of orientation, when we cut the ventricle through the 4-chamber view, we have both the right ventricle and the left ventricle in our field of view. When we tilt the transducer to the 5-chamber view, we get more like this orientation. And here we have the 5-chamber view. And we can also rotate the transducer from a 4-chamber view clockwise to achieve an atypical lateral view. So it looks like a 5-chamber view, but it just shows different parts of the left ventricular walls by means of rotation. Here you have the lateral parts of the left ventricle nicely displayed. Regional wall motion abnormalities in this area can only be seen in this view. You also get the glimpse of the LVOT and the aortic valve, and you can quantify aortic regurgitation. Now that we have discussed the 4-chamber view and atypical views, including the atypical lateral view, focused view of the right ventricle, the left ventricle, and the coronary sinus view, and of course the 5-chamber view, we will move on discussing the 2-chamber view and also the apical long axis view by means of the apical views. Again, how to achieve the views? You stay at the apical parts of the left ventricle. This is a highly variable view. You start with the 4-chamber view, the marker pointing towards the left side of the patient. The patient is not entirely left lateral, and then you start with a rotational movement counterclockwise, always keeping the structures you want to see in your field of view. So remember, 5th intercostal space, approximately go to the point where you feel probably the heartbeat, or where you just simply see the left ventricular apex, the marker left lateral, the rotation counterclockwise for the 2-chamber view, it's 60 to 90 degrees. From the 4-chamber view, for the apical long axis or 3-chamber view, it's 90 to 120 degrees. The apical views, to recall them, for the 4-chamber view, you have this orientation, and then you start the rotation and continue rotation until you see the structures you need to find. So with a counterclockwise rotation, approximately 60 to 90 degrees, you cut the heart from this perspective, visualizing the left ventricle and the left atrium. And then if you continue more, 90 to 120 degrees, you find the apical long axis view. So it's called apical long axis because it's simply the same structures to be visualized what you have seen with the parasternal long axis view. If you want to see the parasternal views, there's an entire video designated for only the parasternal long axis view. The two-chamber view, what can you see? You see the entire inferior wall and anterior wall. This is a focused view of the left ventricle, and you can see parts of the mitral valve, the AMVL and the PMVL. About the mitral valve we will talk in detail a little bit later. Also the coronary sinus can appear here, and you will need the measurements of the left atrium as well. So perform a normal two-chamber view where you see the left ventricle and the left atrium, and the focused two-chamber view, for example, for ejection fraction calculation or strain imaging. Why the two-chamber view? Of course, it's about the global longitudinal function, the ejection fraction, wall motion abnormalities, is a regional left ventricular function, and also about the valvular and the atrial structures. Here we have two examples, two patients. We have here an apical wall motion abnormality in an anterior STEMI, an anterior ST elevation myocardial infarction, and on the right-hand side we have a HFrEF, so a heart failure with reduced ejection fraction in ischemic heart disease, where you can see the truly severely reduced left ventricular function. In this case, we have an inferior wall STEMI patient. This patient had a STEMI in the inferior wall. We do see here akinesia of those segments. We see normal contraction over here, but here it is truly akinetic, so there is no movement. There's also thinning of the wall, so this is probably already scarring of the left ventricle. And on the right-hand side, we do see a hyperdynamic left ventricular function. There is severe mitral regurgitation present. We do see atrial fibrillation, a hyperdynamic left ventricular function, also pointing towards the severity and the really severe mitral regurgitation. Visualizing the coronary sinus view, here you have it very, very subtle, very small. In this case, it's truly an enlarged coronary sinus. This is most likely in this young patient due to a persistent left superior vena cava. So many structures you can visualize in only a few angulation and views. Why the two-chamber view for the valve? It's about the mitral valve, mitral regurgitation, mitral stenosis, and here in this case you see nicely a flail leaflet. Here you see it as well, the truly broad jet origin in this patient with a flail leaflet. Which part of the mitral valve we will discuss shortly. Now continuing from the two-chamber view, counterclockwise rotation approximately 30 degrees. Overall from the four-chamber view it's 90 to 120 degrees. You are then seeing the apical long axis view. The apical long axis view, you can see the left ventricle, the left atrium, the LVOT, the aortic valve, parts of the ascending aorta, the mitral valve, and to a lesser degree also the right ventricle. So the right ventricle is allowed to be in the field of view. So the apical long axis view resembling the parasternal long axis. Here you have the apical long axis with the mitral valve, the anterior and the posterior mitral valve leaflet, the aortic valve, aorta ascendens, the right ventricle, parts of the tricuspid valve, the left ventricle, the left atrium, and here you see the left ventricle, the left atrium, the mitral valve, anterior, posterior mitral valve leaflet, aortic valve, the LVOT, here the right ventricle. So it's actually the same you can see in those images, just it's a different angulation and different focuses you are looking at the structures. Here, for example, in the parasternal long axis view, you do not want to see the apex of the left ventricle. Here it is essential that you also visualize the apex, again for measurements, for wall motion abnormalities, for strain imaging, and so forth. It is important to visualize all three dimensions of the left ventricle and also three views. Here we have the four-chamber view in these three plane modes, the two-chamber view Here already the aortic valve comes in our field of view, so it's in between the 2 and the 3 chamber view, the apical long axis view. And here long axis view, where you already are a little bit over-rotated towards the right ventricle. But with this view, with this modality, you can easily visualize the various views of the heart of the left ventricle easily. Why the 3 chamber view? Why the apical long axis view? Well, wall motion abnormalities we discussed. Thrombi, hypertrabeculations, thickening of the left ventricular walls, strain imaging. You want to visualize the mitral valve, the aortic valve, the LVOT, to see LVOT obstruction, aortic stenosis. So it's also an important view to have in each and every echocardiographic exam. Here we have an example of a wall motion abnormality where we see the inferolateral region is contracting nicely. There is a normal thickness of the myocardium starting from the apical region, so lateral, and then the apex and the anteroseptal regions. We do see a large scar in a patient with coronary artery disease after a large myocardial infarction. You see the walls here are thin, they are hyperechoic. Here the walls look normal. Aortic valve and mitral valve. Overall left ventricular function due to the hyperdynamic contraction of the inferolateral segments doesn't look severely depressed, but with such a scar, of course, left ventricular function has to be significantly reduced. In this case, we have several problems. We have aortic stenosis, where we see turbulent flow and just little movement of the valve. We have aortic regurgitation, which is directly located at the anterior mitral valve leaflet. We can see that there must be mitral regurgitation present as well. We do see a thickened heart, so a petrified heart due to aortic stenosis most likely. We would also visualize mitral stenosis in this view if there would be any present. Let's talk again about mitral regurgitation and visualize this patient with severe MR. We have a hyperdynamic left ventricular function. We have a normal aortic valve, and we do see here the flail leaflet. So that's the posterior mitral valve leaflet, and there's the flail leaflet. Here's the anterior part of the mitral valve. And we can see here that the origin is where the flail leaflet is actually at. We have a large convergence zone. We have a mitral regurgitation thread, which is definitely not central, it's eccentric, which is also common in this kind of pathology. So it's a primary MR due to a flail leaflet of the posterior leaflet of the mitral valve. Now, the mitral valve problems are very often difficult to interpret. Valvular problems can be difficult overall. The mitral valve, the mitral regurgitation, mitral stenosis, aortic regurgitation. In this patient, we have an apical long axis view where we do see again, problems of the mitral valve. That's a patient with Barlow's disease, so a prolapse of both thickened mitral valve leaflets. The same with wall motion abnormalities holds true for the mitral valve. You need definitely more than one view. You need a 4-chamber view to see different parts of the mitral valve compared to the 2-chamber and the apical long axis view. Why is that important? First of all, it's important to realize, is this secondary mitral regurgitation due to ventricular or atrial dilatation, or is it primary MR, where there's really a problem of the valve itself? And the orientation of the mitral valve and the views you have is important to understand to really see where the problem actually lies. So in case of the parasternal short axis view, where we see all the areas of the leaflet, it's different with the apical view. So in the parasternal short axis view, we have A3 and P3, A2 and P2 in the middle, and A1 and P1 at the anterior lateral commissure. The posterior medial commissure, there we have A3 and P3. In the 4-chamber view, it's not always that clear. We have A3 or A2 and most likely P1 to P2. In the apical long axis view, we have P2 and A2. And in the 2-chamber view, we have P3 and P2 and also the A2 segment, which is seen over here. It's not always the same. It's not always easy to actually assess with a TTE study where the problem of the mitral valve is, but at least you can have a guess and then continue to your TE study. So in this case, we have several images and several loops, and we do see the several segments. We can see here the parasternal short axis view, here the parasternal long axis view, and the 4-chamber view, the 2-chamber view, and the apical long axis view. So with all of this, you can see the different segments of the valve and you can try to differentiate where the lesion actually is. Here we have examples where MR is present, and you see here there's definitely MR in the apical long axis view. So there's a problem in the P2 segment. We have it in the two-chamber view as well. So that might be even P3, maybe A2 as well. We have here another example where the P2 segment seems to be involved. In the four-chamber view, we are visualizing the same MR again, and then the apical long axis view. In the parasternal long axis view, we can prove what we have seen in the apical long axis view. So let's summarize. In this case, we have a morbus Barlow patient. We have a prolapse of the mitral valve where we figured it could be P2, P1, P3, and probably even A2, where we have this mitral regurgitation. And now we need to move on to the TE study to actually visualize where the most prominent prolapses and the most prominent pathologies of the mitral valve are. Here we have the TE study, and you see the long axis view, the mid-esophageal long axis view, and the mid-esophageal two-chamber view, where you see the same parts of the mitral valve. We use color Doppler imaging to visualize mitral regurgitation. We can see the four-chamber view as well with the prolapse, and it becomes easier to quantify and easier to describe the problems when you see a 3D image. And in this case, it's the other way around. We have a problem of the P2, P3 segment. Here we can see it P2, P3, that would be P1, probably partially also involved. The A2 segment we see here as well, and A3 as well. But this is definitely no partial flail leaflet, and with the color Doppler origin, we can quantify or semi-quantitatively assess the severity, and overall in this case with the morbus Barlow, it was still severe mitral regurgitation, even though at some glances of just looking at the color Doppler jet, it was not that clear. But look at the large orifice where the flow can actually happen and cause mitral regurgitation. The nowadays technology also has brought us that far that we can visualize even valvular structures with a TTE approach. Here I have an example where you see the tricuspid valve, the three leaflets, and here the mitral valve, to the anterior and the posterior mitral valve leaflet. So the longer anterior, here is the LVOT. You even can see the aortic valve very nicely displayed. So what's going on overall in the apical areas, the apical views? They are almost endless views. You need a four-chamber view, two-chamber view, three-chamber view, which is the apical long axis view, five-chamber view, coronary sinus view, atypical lateral views, but this is only assessing the left ventricle. To quantify, you have plenty of measurements at hand: the mitral valve, the aortic valve, tricuspid valve, more motion abnormalities, left ventricular function, right ventricular function, and much, much more. If you're interested in evaluating the right ventricle, go to the designated video and check it out to see how the right ventricle and how right ventricular pathologies can look like and can present. Furthermore, this video sums up the apical views with a focus on the left ventricle. Stay tuned for more chapters in the compact echo course.